right, welcome back to another episode of Back Talk. I'm Dr. Christopher Blanchard, a spine surgeon with the Resurgence Orthopedics and the co-medical director of the Resurgence Spine Center.
And I'm Dr. Jason Velez, also a spine surgeon at Resurgence Orthopedics.
And here today, we're going to talk about disc replacement.
Yeah.
It's been a hot topic recently. And we're going to talk a little bit about the evolution of disc replacement, some disc replacements in the neck or cervical spine, as well as the low back. Jason, when was your sort of first exposure to disc replacement?
First exposure was in my fellowship about 16 plus years ago, mostly entirely in the neck. So where I trained at Ortho Carolina, we were the lead center for the cervical arm of the disc replacement study for the Pro Disc. So we did a lot of those. Never partook in a lumbar disc replacement during training. And I've only done a handful of them in select few patients. But obviously I was a little ahead of the curve as they were just wrapping up the study. But you being a little later, what was your experience?
Yeah, so I did, sort of was first exposed to it mainly in fellowship as well. And sort of time frame wise, I think when I went through fellowship, the pendulum had swung from when you were kind of going through training where we were starting to do a lot of cervical disc and a lot of lumbar discs. When I was going through fellowship, the pendulum as far as lumbar disc had swung completely back the opposite direction. There were very few of them being done. Right. They were much more selective. And so I think a lot of that research came out of the earlier years of disc replacement and made us sort of take a pause and go, okay, wait a minute, what are our outcomes really with these lumbar disc replacements? Right.
No, exactly. And again, with the earlier iterations coming out of Europe, the Charité and all that, it was new. It was 25 plus years ago. And, we learned a lot from those. And, hopefully the idea was to build better, longer lasting, more appropriate type of replacements as, those older ones are no longer on the market. As a result.
Let's do this. I feel like cervical and lumbar disc replacement are two completely different animals.
I agree completely.
When it comes to cervical disc replacement, what's your indications for doing cervical disc replacements?
So I'm pretty by the book as it was taught or as we adhered to it during the studies, in that soft disc herniation, that is to say, no significant amount of degenerative arthritic kind of issues. That's pretty much it.
Yeah.
If there was slight degenerative issues at 2 levels, but only one needed surgery, that would be one where I would consider doing a disc replacement, so as to spare the one that is not as far along.
Right.
And that's kind of still how that's still my lane for the most part.
Right. I think I fall in a similar category. I think over the last couple of years, as some of the research has come out, I've become a little more aggressive or maybe a little more lax on the amount of degenerative changes that I'm willing to accept. And it's funny when I talk to patients about disc replacement, I'd say, it's a mobile bearing device, sort of like having a knee replacement, except we usually do it in the opposite demographic of patients, right? We're not really working a lot with patients with significant degeneration and the same way you would with a knee or hip replacement.
Correct.
And so I sort of fall along those same lines where it's, usually a younger patient. Well, honestly, it doesn't really have to be younger, just more of a soft disc herniation that's causing nerve compression and radicular pain. to your point, do they have some adjacent segment disease already that you're worried, okay, if I fuse this level now, is that going to cause worsening of that? And so I would agree. I follow along the same lines. I will say that I have gotten a little more aggressive in terms of some of the degeneration that I'm willing to accept.
Most people have. And,
yeah.
I'm further along than I was.
Yeah.
But
how about lumbar disc, right? So we would say that, this is kind of a completely separate animal. And our experience in, sort of recent history with disc replacement, we've seen a huge divergence in terms of patient satisfaction with lumbar disc versus cervical disc replacement. What's your indications for lumbar disc?
a lot narrower.
Yeah.
A lot narrower. So just to kind of put it in perspective, a lot of times what I'm thinking, well, just for the audience out there, to do a disc replacement in the low back, you have to go in through the belly.
Mm-hmm.
Okay. So, I have to somehow rectify how that would be better than a fusion.
Mm-hmm.
So in general, a lot of times when I'm fusing a patient, it's someone who's already had surgery in their back. They may have another disc herniation, or they may have had bone removed in the back, or they may have a slight slip where the bone is a little unstable, which automatically should exclude them for consideration for a disc replacement. Right. So, there's that. So then at the same time, you're also looking at the degenerative changes and how they may impact the patient's symptoms. And then it's a question of, okay, for me, what's the age of the patient and what am I trying to gain? Because, the studies have not shown, they were not in non-superiority studies. Mm-hmm. So they were never shown to be better than fusion.
Right.
In terms of pain relief or symptomatic recovery, only in maintenance of motion.
Right.
And protecting the levels above. So, if I have a dead normal level above a very bad disc, depending on the age, because we only have 20, 25-year data as to how long these things last, I would probably still err more towards the fusion.
Yeah.
But for some patients that may be a little older, but still physiologically everything looks good, I've put disc replacements in them because I'm banking on the fact that it's going to outlast them.
Yeah, and that's a great point. As we're talking about disc replacements, a lot of times we're seeing younger patients, right? We're talking 30s and 40s. And like you said, we've got good 20, 25-year data, but that's still only getting us to 55, 65. Right. And then so what happens after that? And I think the interesting thing about lumbar disc versus cervical disc is the indications for me almost completely change, in that for cervical disc, really what I'm looking for is nerve compression, radiating arm pain. Right. It's exceedingly rare, and I can't remember a time off the top of my head where I've done it specifically for neck pain. But then for lumbar disc, it's kind of the exact opposite, where we're not really doing. And I actually had a surgery denied because the patient had complained of radicular pain. And so the insurance company denied the lumbar total disc because what they want to see is no radicular pain, no nerve compression, isolated back pain, and it becomes much more difficult to, in my opinion, with lumbar disc to really isolate the cause of it, right? Because it can be discogenic pain, it can be facet-mediated pain, and so working through those things with patients to make sure that, hey, this is what's causing the issue, right. Because that's what's going to give us the predictability, after surgery.
Right. Now, I often joke with patients, it's very simple math with the neck, nerve hurt, disc on nerve, remove disc, nerve better.
Yeah, exactly.
Back, it's like back hurt. Back still hurts, and we don't know why.
Yeah, exactly. Yeah. Hey,
Injections haven't worked.
Right.
Medications haven't
Yeah.
worked. PT hasn't worked.
yeah. And so I find in my practice that the demographic for lumbar disc replacement is much, much, much more narrow than it is for cervical disc replacement. And, for me, it's really younger-ish patients that really have isolated disc degeneration at just one level.
Right.
And if I'll usually send them for facet injections to kind of see, okay, is it pain coming from the joints in the back of the spine and not the disc space, to try to just get as much information as we can to make it as predictable as possible. And I think with those things, the more specific you are and strict to the indications, the better the results are going to be.
Yeah, 100%. And, again, the new device, again, we have to remember that patients are coming into this thinking about joint replacements.
Right.
Where it's like, okay, these things last forever, good quality of life. Well, not last forever, but last for 15, 20 years, right? And that it is the epitome of what could be done for quality of life in these individuals. But again, with the neck and the back, we don't have the data yet to support the same sense of it in terms of duration of longevity of these materials, but also that it's not the quality of life still comes down to alleviating the nerve symptoms for the most part. So you could do that just as well with a fusion.
Yeah, and I, as I mentioned on another one of our episodes, I will commonly tell patients, hey, you don't want a disc replacement, you don't want a fusion, you want your symptoms to go away.
Right.
And so I commonly will tell patients, especially with cervical discs, hey, plan A is a disc replacement and plan B is a fusion.
Yeah.
And I have both options available because my goal is to take the pressure off of the nerve, relieve your symptoms, and then also explain to them that for a one-level surgery, our research shows patients don't really notice the difference.
No.
I saw a patient today, 6 months out from a one-level cervical fusion, and he's moving his head. I don't think I lost anything. And I told him, yeah, that's what our research would show.
Yeah.
Now, 2 levels, we do start to see more difference in terms of the outcomes with range of motion or adjacent segment disease. But for one-level surgery, for instance, my wife has, radiating arm pain, and she may choose to have surgery, and I would be perfectly comfortable with her having either surgery,
right?
Whatever relieves her symptoms.
100%. Yeah, like I tell patients all the time too. I'm like, look, I could do either one of these, and you'll be equally happy. But when it comes down to range of motion, I'm like, well, let me see you move your neck now. Well, they're already coming in with restricted motion.
Right.
So I usually tell them, look, if I fuse 2-3 levels in your neck, it's not going to be any worse than it already is.
And I commonly get that same question is like, okay, well, if you, and again, when you talk to patients about fusion, they sort of get this look on their face. And I commonly tell them, okay, well, you should lose roughly 10% of your range of motion for each level that we fuse. But you're also not 18, right? So your range of motion isn't full now. Those levels already aren't moving normally. So, if it were a 2 or 3 level, you're not going to lose as much as you think you would. I think for me, the advantage that I've seen mainly with cervical disc replacement is the short-term recovery afterwards, meaning that I have fewer restrictions for less amount of time after a disc replacement than I do a fusion.
Yeah, 100%.
And I'm not worried about, okay, is it going to fuse? Is it not going to fuse? Are my screws or my plate going to break or come loose? It's so I would say from an immediate sort of short term 6 to 12 week time frame, I'm much more comfortable with it because I know, okay, I can after 6 weeks, I pretty much let them do what they want to do, and so for that perspective, it's less worry for me.
Yeah. No, I agree. I agree. I mean, that all tracks, and to your point earlier about, you could do either or. Sometimes I explain to them, we're going to plan for a disc replacement. That's what we're leading with. I'm going to bring in a fusion into the OR2 just in case, because if we put the implant in there, it's not stable, or we had to remove more bone to take the pressure off the nerve than we thought we were.
Exactly.
This is what's going to end up happening, and I'd rather do it then and there as opposed to there being a failure and having to go back in later. So I always have that discussion with the patients too. But yeah, it's not a fix for everything. And, aside from the neck ones where there are some devices with FDA approval for 2 levels, that does not exist for the lumbar. And again, that's usually an issue for a lot of patients in that they have multi-level disease, which then excludes them from consideration.
Yeah, and I think that for me is one of the biggest issues, right? I want to give patients good, predictable outcomes.
Right.
And we can do surgery on whatever's going on, but that doesn't mean it's going to fix it.
Right.
And so we want to be as specific as possible. And that's why with lumbar disc, if they've got 2-3 level disease, maybe a little bit of arthritis in the joints of the back of their spine, those are patients that I'm much more concerned about. Hey, we may do this disc replacement, but there's several other things that could be causing your pain. With the cervical spine, I'm much less worried about that.
Yeah, there's less variables. I agree.
Yeah. And I think patients, the demographic tends to be much broader in terms of the indications for that.
Yeah, no, I agree. I mean, the take-home point is, newer isn't always better, and sometimes there's still a role for the old standby, and the research supports that.
And I think an important thing to know, just like you said, it's the indications in doing the right procedure. And one of the sort of downsides to disc replacement, lumbar and cervical, is that because of the makeup of the implant, they have to be a certain height, right? Yeah. And so I will run into patients where their disc space is so collapsed down that you literally can't open the disc height up enough to get the smallest disc replacement in. And one of the implants that I use, the smallest size is a 5, but that is the size that we use most of the time. And normally in sizes, it's a bell-shaped curve, and we use the middle one the most. But in this instance, we use the smallest one the most because most of the time that disc is narrowed down so much that you're not going to get a much taller disc space or a much taller implant. And so I've had a patient recently that was seeing me for a second opinion. Another person had offered them a disc replacement. They had really bad facet arthropathy in the back of their neck, really collapsed disc space. And I said, hey, you could probably do it, but I don't think it's going to be the best thing for you. I think you're going to have a lot of trouble getting that smallest implant in. I think you're going to still have pain in the back of your neck from what's going on, and sort of left it up to them. And so making sure that the patient meets the right indication and that you can actually do the procedure based on their anatomy and the implants we have available.
100%, because the goal is to, maintain mobility of the implant. But if you are overstuffing the space, you just made it a de facto fusion.
Right. Yeah, and that's
because it's not able to
yeah.
move.
I've seen several patients that have had cervical fusion years and years ago at other facilities, and not that there's anything wrong with them, but a lot of times you see them ankylose, right? You see them fuse across there, and there's some things we can do to sort of help prevent that, but that absolutely is one of the things that can happen.
Yeah, 100%.
And that's why I think one of the biggest takeaways that I tell patients is, hey, you don't want a disc replacement or a fusion. You want the procedure that's going to make your symptoms go away. And
I'm going to co-opt that.
Yeah,
and I'll give you full credit. I'll cite you.
Well, but you say the exact same thing, or I say the exact same thing you say in terms of, hey, we're going to go in, we're going to decompress the nerve. And I say, we do whatever we need to do to decompress that nerve. Then if I can give you a disc replacement, fantastic. Yeah. If I can't, I've, done fusions on active duty FBI agents and sheriff deputies and people with, tough manual labor jobs. And they've done fantastic.
Yeah.
Peyton Manning had a 2-level fusion, won the Super Bowl afterwards. I know your thoughts on the defense, but
it's all about the defense.
But and Tiger Woods had a lumbar fusion and won the Masters afterwards.
That's all Tiger.
Yeah,
that's all Tiger.
That is old. Yeah, but just the idea that, hey, you want the appropriately indicated surgery to get rid of your symptoms.
Right.
If we can do that in a way that maintains mobility or maybe gives you a quicker recovery, yes, that's a great option. But ultimately, you want resolution of the symptoms.
Yeah, and because that's what we're here to do.
Right.
Help you have a better quality of life. So...
Well, I hope this episode has answered some questions or maybe cleared up some misconceptions or given you a little more information on cervical and lumbar disc replacement. I would tell patients, hey, if you're having an issue and maybe considering surgery, talk with a surgeon who does disc replacement, but also understand that it's not the best option for every indication to treat every patient, but can be a really good option in the correctly indicated patient.
Yeah, it's got to be custom fit. You're not going to buy a wedding dress off the shelf.
Agreed.
Pure and simple.
Thank you for joining us for this edition of Back Talk.
And I'll give another hot one. Thank you for joining us for this edition of Back Talk.